Welcome back, fellow mitochondriacs, for an episode of Cancer as a Mitochondrial Metabolic Disease. Antioxidants are widely considered as healthy. They reduce oxidative stress, they protect cells, they're often recommended for longevity purposes. However, in cancer, this may be a very different story. In fact, multiple studies have found that certain antioxidants are associated with worsening clinical outcomes and, in some cases, increased mortality. So, what's really going on here? In this video, we're going to talk about why taking certain antioxidants may be harming your progress. So without further ado, let's get into it. So this is a video that I had been meaning to do for a long time. This is a video that is, I would say, somewhat controversial and paradoxical and somewhat difficult to conceptualize because we have been, including me, we've kind of been indoctrinated to think that antioxidants are good, autophagy is always good. These things are always good. And really, these things are tools, that we can use to help improve our health. And in some cases, it may not improve our health. And in this case, we're talking about, is it safe or good to use antioxidants with cancer? And there's a lot of nuance here. So I'll probably make this into at least two videos. I'm going to talk about the reasons why we probably would not want to use antioxidants and give examples of which ones those will be. In the next video or two, we'll talk about some of the gray areas and even where some antioxidants, quote unquote, are likely helpful. So I'm going to start out by showing this paper that was published in August of 2025, and it's called The Effects of Antioxidants on Cancer Progression. And it says here in the abstract that antioxidant supplements are widely marketed for their promised health benefits, including cancer prevention and therapy support. This belief stems from the idea that excess levels of reactive oxygen species cause oxidative damage to cellular macromolecules. However, the effect of antioxidants are highly context dependent and influenced by compound type, dosage, and cancer type. While antioxidants may slow tumor progression in certain cancers, such as MYC-driven lymphoma, they can accelerate tumor growth, metastasis, and angiogenesis in other settings, such as KRAS-driven lung cancer and BRAF-driven melanoma. Certain antioxidants may also influence the immune system in ways that support cancer therapy, such as immune checkpoint blockade. However, we review recent studies that highlight the complex roles of antioxidants in cancer progression and discuss their potential therapeutic implications. And basically in the conclusion, I clipped it out and it says here, these studies highlight the complex and context-dependent effects of antioxidant cancer. The effects of antioxidant compounds vary widely depending on factors such as compound type, dosage, route of administration, cancer type, disease stage, and genetic background. While antioxidants like NAC, vitamin C, and vitamin E can substantially promote tumor growth and metastases in several contexts, particularly through BACH1 activation and stimulation of glycolysis and angiogenesis. They also show therapeutic potential in other contexts, including leukemia, MYC-driven B-cell lymphoma, and immunotherapy responsive tumors. Antioxidants affect cancer biology via several different mechanisms, such as modulation of redox homeostasis, alteration of metabolic pathways, regulation of transcription factors, epigenetic reprogramming, and immune response modulation. This functional heterogeneity demands clear-cut evidence-based guidelines for antioxidant use, particularly in patients with cancer or increased cancer risk, where dietary supplementation seems to be particularly troublesome. And in particular, I took this piece of the paper out, and it's basically showing how ROS can effectively, in some cases, stop cancer progression if it's in extreme amounts by excess DNA damage and activation of apoptosis. And so when they gave antioxidants in some cases, you can actually make proliferation worse. And so there's just a bunch of different contexts of how antioxidants are kind of either making cancer worse or even improving cancer. And that's kind of where the dilemma is at. Like here's another example of ROS leading to iron-dependent cell death called ferroptosis. And if you give an antioxidant, that can help prevent that. And that's kind of the context that we're going to be looking at. So I pulled this paper next that was published in December of 2022, and it was basically recent progress in ferroptosis, inducers, and inhibitors. And I particularly look at the ferroptosis inhibitors about things that we could potentially use to inhibit ferroptosis. And some of these things like iron chelating agents, most people aren't going to be on those kind of things. But if you look here, we have D-alpha tocopherol, or, the kind of synthetic, most commonly seen in most supplements, vitamin E. Here's selenium. And selenium is one of those double-edged swords that we'll talk about. And so one of the ways I personally believe that these antioxidants are likely going to make things worse for us is their ability to help cancer, which is already on an edge of redox homeostasis, find a better balance and foothold, and also lead to therapy resistance for not only metabolic therapies, which try to hamper the antioxidant systems within cancer and potentially throw it over the edge using oxidative therapies, but also things like radiation therapy and some chemotherapies are also going to be likely hampered by some of these antioxidants. So here's, mechanisms of vitamins inhibiting ferroptosis. Multivitamins, including vitamin A, some B vitamins, C, D, E, K, have been shown to have good ability to inhibit ferroptosis. Some of the next papers I'm going to be going over will be talking about glutathione. And this one was published in 2013. It says the role of glutathione in cancer progression and chemoresistance. And it says glutathione plays an important role in a multitude of cellular processes, including cell differentiation, proliferation, and apoptosis, and disturbances in glutathione GSH homeostasis are involved in the etiology and progression of many human diseases, including cancer, while GSH deficiency or glutathione deficiency or a decreasing glutathione disulfide GSSH ratio leads to increased susceptibility to oxidative stress implicated in the progression of cancer. Elevated GSH levels increase the antioxidant capacity and the resistance of oxidative stress as observed in many cancer cells. The present review highlights the role of GSH or glutathione and related cytoprotective effects in the susceptibility to carcinogenesis and the sensitivity of tumors to cytotoxic effects of anti-cancer agents. So I think this makes at least a point that is somewhat important. So this is really hard to transmit this information or this idea, but as a protective measure before cancer has established, and we may not always know when that is. That's kind of the gray area here, because some people don't realize they have cancer until they present to the ER with abdominal pain or shortness of breath or something like that. But for those who don't have an obvious cancer, antioxidants like glutathione, like some of these other antioxidants are going to be talking about, probably have a protective role at preventing cancer to some degree. It's always a balance of we don't want to overdo things, but it likely has a protective role. But when cancer is established, then these antioxidants that we give or could take by mouth or by other routes could likely lead to a cytoprotective or a cell protective role, not just for our normal cells, but for the cancer cells and make them more resistant to treatment. That is the concern. The next paper is titled Glutathione Metabolism and Cancer Progression and Treatment Resistance, published in July of 2018. Glutathione is the most abundant antioxidants found in living organisms and has multiple functions, most of which maintain cellular redox homeostasis. Glutathione preserves sufficient levels of cysteine and detoxifies xenobiotics while also conferring therapeutic resistance to cancer cells. However, GSH metabolism plays both beneficial and pathogenic roles in a variety of malignancies. It is crucial to the removal and detoxification of carcinogens, and alterations in this pathway can have profound effects on cell survival. Excess GSH promotes tumor progression, where elevated levels correlate with increased metastases. In this review, we discuss recent studies that focus on deciphering the role of GSH or glutathione in tumor initiation and progression, as well as underlying mechanisms of how GSH glutathione imparts treatment resistance for growing cancers. Targeting GSH synthesis utilization, therefore, represents a potential means of rendering tumor cells more susceptible to different treatment options, such as chemotherapy and radiotherapy and HBOT and IV vitamin C and metabolic therapy in general. This is what we've been talking about in this oxidative stress series. So the next paper was published in December of 2024. Excessive glutathione intake contributes to chemotherapy resistance in breast cancer, a propensity score matching analysis. And in this abstract, it says we aim to explore the impact of excess glutathione intake on chemotherapy sensitivity in breast cancer. Clinical pathological data were collected from 460 breast cancer patients who underwent adjuvant chemotherapy from January 16 to December 2019. In this University People's Hospital, the clinical pathological characteristics following GSH treatment or glutathione treatment were collected and compared to those who did not receive glutathione after 1 to 2 propensity score matching. Intracellular GSH levels and expression of antioxidant enzymes NRF2, GPX4, glutathione peroxidase 4, and SOD1, superoxide dismutase 1, were evaluated in tumor tissues of 51 patients receiving neoadjuvant chemotherapy. It says here the recurrence rate after adjuvant chemotherapy was significantly higher in the GSH group compared to the non-GSH group. Additionally, patients in the HGSH, high GSH intake, exhibited elevated recurrence rates compared to those in the low GSH group. Cox regression revealed that high GSH or glutathione intake showed an increase Ki67 by 30% or more. Triple negative and lymphoblast vascular invasion were independent risk factors of progression after adjuvant chemotherapy. Among patients receiving neoadjuvant chemotherapy, intracellular glutathione levels and expression levels of enzymes in the resistant patients were substantially higher. And in conclusion, it says that excessive glutathione or GSH intake may contribute to chemotherapy resistance in breast cancer, and levels of intracellular GSH and antioxidant enzymes are elevated in resistant patients after neoadjuvant chemotherapy, indicating that the standardization of GSH intake may assist in reducing chemotherapy resistance. So this is one mechanism of how chemotherapy can have less of an effect on cancer. I call this the internal shield system of the cancer. The external shield system, just so everybody's on the same page, is the tumor microenvironment or the acidic tumor microenvironment. That can lead to chemotherapy resistance, immunotherapy resistance, etc. But the internal shield system is the antioxidant systems within cancers that we're trying to downregulate or basically maim as a way to enhance our chances of these, whether it be standard of care or oxidative therapies that we employ through metabolic therapies to have a better effect. And this is just one paper looking at how giving glutathione to people with breast cancer getting chemotherapy worsens their survival and their chances of getting recurrence. This next paper we're going to look at was titled Knack Knocking on Heaven's Door, Interpreting the Mechanism of Action of N-acetyl-l-cysteine in Tumor and Immune Cells. Now, up until this point, we've looked at glutathione as a supplement, either intravenous or by mouth, etc. What does NAC do? NAC is responsible for increasing glutathione. Matter of fact, we give NAC patients who have Tylenol overdose or liver problems. So NAC, I'm not demonizing it. It's in my cabinet right now. The thing is, it's just that it's context dependent. So there are many things that NAC can do, including lower blood glucose, et cetera, help with detoxification. It's just that when it's in a cancer model, it's very likely not going to be great. So it says here in this abstract, N-acetyl-l-cysteine, NAC, has been used as a direct scavenger of reactive oxygen species, hydrogen peroxide in particular, and an antioxidant in cancer biology and immuno-oncology. NAC is an antioxidant drug most frequently employed in studies using tumor cells, immune cells, and preclinical mouse xenografts. Most studies use redox active fluorescent probes such as dichlorohydrofluorescein, hydroethidine, mitochondrial targeted hydroethidine, and proprietary kit-based probes for intracellular detection of superoxide or hydrogen peroxide. Inhibition of fluorescence by NAC was used as a key experimental observation to support the formation of reactive oxygen species and redox mechanisms proposed for ferroptosis, tumor metastases, and redox signaling in the tumor microenvironment. Reactive oxygen species such as superoxide and hydrogen peroxide stimulate the aggregate tumor cells and immune cells depending on multiple factors. Understanding the mechanism of antioxidants is crucial for interpretation of results because neither NAC nor fluorescent probes indicated above react directly with hydrogen peroxide. It is critically important to reinterpret the results to advance our understanding of the underlying mechanism action of NAC and shed additional mechanistic insight on redox regulated signaling in tumor biology. To this end, this review is focused on how NAC could affect multiple pathways in cancer cells, including iron signaling, ferroptosis, and glutathione-dependent antioxidant and redox signaling mechanisms, and how NAC could inhibit oxidation of the fluorescent probes through multiple mechanisms. This abstract was not very well written, I'll be very honest with you. It is mixing things that are what I would say clinically relevant with things that are relevant in the labs. What I will say is that NAC has double-edged sword, so it can, as this graphic says, it can promote metastases, it can inhibit ferroptosis, it can enhance our thioredoxin systems, that's the glutathione systems, it can modulate NRF2, stimulate glutathione, modulate the immune system. So there are pros and cons. And however, when we look at it at the level of clinical outcomes, we'll see that there's probably more cons than goods. The next paper we're going to look at was published in January 2014, and it's called Antioxidants Accelerate Lung Cancer Progression in Mice. We show that supplementing the diet with antioxidants NAC, N-acetyl-l-cysteine, and vitamin E markedly increases tumor progression and reduces survival in mouse models of BRAF and KRAS induced lung cancer. RNA sequencing revealed that NAC and vitamin E, which are structurally unrelated, produce highly coordinated changes in tumor transcriptome profiles dominated by reduced expression of endogenous antioxidant genes. NAC and vitamin E increase tumor cell proliferation by reducing ROS, DNA damage, and PPD3 expression in mouse and human lung tumor cells. Next paper. This protein was highlighted in the first paper. It's published in July of 2019. BACH1 stabilization by antioxidant stimulates lung cancer metastases. Here we show that long-term supplementation with antioxidants NAC and vitamin E promotes KRAS-driven lung cancer metastases. The antioxidants stimulate metastases by reducing levels of free heme and stabilizing the transcription factor BACH1. BACH1 activates transcription of hexokinase 2 and GAPDH and increases glucose uptake, glycolysis rates, and lactate secretion, therefore stimulating glycolysis-dependent metastases of mouse and human lung cancer cells. So basically, ROS is an interesting concept, and I don't think anybody has it all figured out, but when ROS is elevated, it can stimulate pseudohypoxia, stabilize HIF-1 alpha, and can increase the Warburg metabolism. When ROS is excessive, then if you give antioxidants, it will quench the ROS enough to where it will actually make it worse. When ROS is high, like super high, it will actually have a negative feedback and it will lead to usually cell death or retarded growth of these cancer cells. So by giving these antioxidants, in this case, NAC and vitamin E, it probably quenches the ROS enough to where now this cancer system, particular case, this lung cancer model, can have more proliferative capacity. And that's where the double-edged sword really starts to become very difficult to determine. This paper was published in June of 2016. Vitamin E promotes breast cancer cell proliferation by reducing ROS production and p53 expression. It says here the role of antioxidants in cancer cell proliferation is still controversial. This study aimed to explore the effects of antioxidant vitamin E on the proliferation of breast cancer cells and the possible underlying mechanisms. And it basically says in the results that vitamin E supplement in the chow of these mice significantly accelerated breast cancer cell growth in vivo. ROS levels and p53 expression were decreased in tumor tissues. Conclusion: vitamin E accelerated breast cancer growth by reducing ROS and p53 expression. Now, I will be transparent. This is very likely going to be D-alpha tocopherol. Keep that in mind. Here's another paper that was published in April of 2023. ROS lowering doses of vitamin C and A accelerated malignant melanoma metastases. So I'm going to touch more on this when we get into specifically intravenous vitamin C. But needless to say, pretty much any dose orally, liposomally, or even low dose intravenous is going to have an antioxidant effect, what we classically think about when we think about vitamin C. And it's going to have very likely a tumor promoting effect. Now, are there stories of people taking very high doses of oral vitamin C or liposomal vitamin C and not having worse outcomes? Yes. But mechanistically, that does not make a lot of sense. And so there's going to be X factors we don't always understand. That's why I don't think anybody has it all figured out. But mechanistically, it doesn't make sense to be doing this. And I would recommend against it. Talk to your doctor, decide what's right for you. But mechanistically, this seems like we'd be shooting yourself in the foot. And I would not want someone I love or care about on these oral antioxidants, oral vitamin C, liposomal, etc. Now, when we talk about high dose intravenous, which we will talk about, it is a different ballgame. It is a completely different ballgame. It has a paradoxical pro-oxidant effect. It's actually an oxidative stressor. That is different. Same compound, different concentration, different effect. Here's another paper published in 1996, actually. I'm pretty sure this is the paper that one of my pathology professors when I was in medical school showed us as a way to, demonize natural medicine. And I was very skeptical of it. I still retain some skepticism, even though I'm giving this talk, because I'll explain why. So it's called The Effects of Combination Beta-Carotene and Vitamin A on Lung Cancer and Cardiovascular Disease. And it shows the combination effect of 30 milligrams of beta-carotene per day or 25,000 international units of retinol, vitamin A, in the form of retinol palmitate per day on the primary endpoint of the incidence of lung cancer were compared to the placebo. And it says that in the active treatment group, the relative risk of death from any cause was increased by 17%, and the death of lung cancer was increased by 46%. Now, why am I skeptical about this? The dose makes the toxin. So, do I believe, and this will be part of the gestalt that I have on antioxidants, do I believe that you should be deficient in anything, including things that would be considered antioxidants? No. But should you be mega dosing these antioxidants? And this is what I would consider a mega dose. 25,000 international units of retinol per day is a lot. So my point is, I actually pulled the recommended daily allowance here. So here is, the RDA for vitamin A, right? We're talking micrograms, less than 1 milligram, and they were giving 30 milligrams of vitamin A. So these are mega doses, okay? And it increased risk of death from lung cancer by 46%. So not what we want to do, right? We don't want to be mega dosing. We want to find that Goldilocks of not being deficient, but also not probably doing more than what you would want. I just pulled this graphic because it's just showing how CoQ10 is protecting against lipid peroxidation and ferroptosis for cancer cells, which kind of sets up this next paper here, which is titled Dietary Supplements Use During Chemotherapy and Survival Outcomes in Patients with Breast Cancer, enrolled in this cooperative group clinical trial that was published in March of 2020. And it says there were indications that the use of any antioxidant supplements, vitamin A, E, C, carotenoids, coenzyme Q10, both before and during treatment was associated with increased hazard of recurrence, increased your risk of recurrence by 41%, and a lesser extent death, but not much. It increased the risk of death of this breast cancer model by 40%. So again, that's why when I see graphics like this, where it's like, okay, yeah, there's like good things with NAC and there's bad things with NAC with cancer specifically. But when you see papers like this and subsequent papers, which we'll look at, we'll see that this is scary information. I agree. This is like mega dosing vitamin A and you have a 46% chance of increased risk of dying. But in this case, it was just any use of any of these antioxidants, and it wasn't saying they were mega dosed, and it still had increased risk of dying from breast cancer by 40%. So I just don't think that this is something that I would want to play with. If it was someone that I love or someone I care about, I would not be messing around with oral antioxidants. Again, the caveat is we don't want to be deficient in anything. So, maybe making sure we're hitting our RDA targets. And there's a lot of nuance. And as a matter of fact, in the next video, we're going to get into that nuance, into those gray areas and see if we can sort out what that nuance is. But for now, supplements to likely avoid, and we'll talk about some of these other ones that we didn't cover today, would be glutamine supplements. If that's not clear by this point, when looking at cancer metabolic disease and glutamine being a major fuel source for cancer, then glutamine would not be a good idea. But glutamine is significant because not only does it fuel cancer in terms of mitochondrial substrate level phosphorylation, but glutamine gets converted to glutamate, and glutamate is one of the 3 amino acids that's made up of glutathione. So it would also be contributing to glutathione and redox homeostasis, IV glutathione, oral or liposomal glutathione, n-acetyl-l-cysteine, L-cysteine, L-methionine supplements, oral or liposomal vitamin C, or any low-dose intravenous vitamin C, D-alpha tocopherol, likely only. We'll talk about that gray area of other tocotrienols in the next video. That's a gray area. Vitamin A, coenzyme Q10. Probably I'm going to touch on this because I've got a lot of questions about astaxanthin. There's a lot of provocative videos out there of people promoting astaxanthin. I was already skeptical because I know it's a very powerful antioxidant. And after doing some deep diving, we'll go into in the next videos about astaxanthin, but probably if it's not a micellar or a nano or liposomal astaxanthin, and it's going to have to be in very high doses, which means that if it's low or moderate doses, we'll kind of talk about what that may be. It's actually still not clear. And probably any dose of standard astaxanthin. At this point, that's what I'm willing to say. MSM, big question mark. Definitely wouldn't want to mega dose selenium. But at the same time, we'll look at why there's a double-edged sword there. And then possibly glycine. Glycine is one of the other 3 amino acids that make up glutathione. Probably not supplementing with glycine would also not be a good idea. And that's where I've talked about in the comments multiple times about should you be using magnesium glycinate, magnesium plus glycine, and other kind of glycinated minerals. But I will put this on the next video as well. But I just want to put this out here of what supplements that I would probably want to avoid if I had cancer. We'll talk about some gray area supplements and areas of supplements that may be helpful that are quote unquote antioxidants that actually have a double-edged sword effect in the next video. If you like videos like this, if this is helpful for you, please like, share, hype, subscribe. Until next time.